Dr. Michael Harper had spent 15 years at Johns Hopkins, one of the world's most prestigious medical institutions. He'd published papers, pioneered surgical techniques, and trained dozens of residents in trauma surgery. When he arrived in the Philippines as part of a medical mission after a devastating typhoon, he brought cutting-edge equipment, advanced protocols, and absolute certainty in modern Western medicine's superiority. What he didn't bring was respect for Dr. Alina Reyes, the Filipino surgeon running the overwhelmed provincial hospital. Alina had trained at University of the Philippines, spent 20 years working in rural hospitals with limited resources, and developed improvised techniques out of necessity rather than choice. When Michael toured her facility, outdated equipment, insufficient supplies, makeshift solutions everywhere, his expression showed barely concealed horror. "Dr. Reyes, I understand you're doing your best with what you have, but some of these methods are frankly primitive. This improvised suction device, this sterilization protocol, these would never pass standards at any accredited American hospital." Elena smiled patiently, the smile of someone who'd heard this from visiting doctors before. "Dr. Harper, we work with what we have. When you have no choice, you learn to improvise safely. These methods work." Michael shook his head. "They might seem to work, but proper medicine requires proper equipment and established protocols. That's not negotiable. Patient safety demands it." He began unpacking his equipments, state-of-the-art surgical tools, advanced monitoring devices, sterile supply kits that cost more than Elena's monthly budget. "Let me show you how trauma surgery should be done." The first days went smoothly. Michael's team handled cases with textbook precision, using their advanced equipment. He performed surgeries Alina had never seen executed so elegantly, with such sophisticated tools and monitoring. His residents followed protocols learned at Johns Hopkins, everything measured and controlled. Michael felt validated. This was what these people needed, real medical expertise, not makeshift improvisation. Then the second typhoon hit. Without warning, a massive storm struck the region with catastrophic force. The hospital was instantly overwhelmed, hundreds of casualties, multiple critical trauma cases arriving simultaneously. And then the power failed. The backup generator ran for 2 hours before dying. Michael's advanced equipment, the ventilators, monitoring systems, electric surgical tools all went dark. His battery backups lasted another 30 minutes, then silence. In the pre-dawn darkness, lit only by flashlights and a few emergency lanterns, Michael stood in an operating room with a patient bleeding out on the table, surrounded by useless high-tech equipment. His hands, trained for precision instruments and perfect conditions, hesitated. Without power, without proper tools, without the systems he relied on, he felt paralyzed. Alina appeared in the doorway, assessing the situation instantly. "Dr. Harper, I need this room. We have 8 critical patients, 3 need immediate surgery, and we have no power for maybe 12 hours. Michael gestured helplessly at his patient. "I can't operate like this. No monitoring, no proper equipment." No, Alina was already moving, her team flowing around her with practiced efficiency. "Then let me show you how we do trauma surgery when we have nothing but our hands and our training." What Michael witnessed over the next 6 hours shattered every assumption he'd held about modern medicine's superiority. Alina operated with tools that would make American surgeons weep. Manual suction devices improvised from tubes and foot pumps. Sterilization accomplished with pressure cookers and alcohol. Lighting from headlamps and reflected mirrors. Monitoring done by hand on pulse and observation rather than machines. Her techniques were adaptations born from decades of working without resources. She'd learned to feel what monitors usually showed, to improvise tools from available materials, to make life or death decisions without the safety net of technology. A young man came in with a ruptured spleen, bleeding internally, minutes from death. In Johns Hopkins, Michael would have used laparoscopic equipment, advanced imaging, precise instruments. Alina had none of that. She operated with basic tools, her hands working with extraordinary speed and precision, using techniques she'd developed for controlling bleeding when you couldn't rely on equipment. She packed the wound with materials sterilized in boiling water, used manual compression methods refined over thousands of similar cases, and stopped the bleeding through pure skill and improvisation. The patient stabilized. A woman arrived with a crushed chest, struggling to breathe. Michael's training called for ventilators, oxygen monitoring, advanced airway management, all impossible without power. Alina intubated using a technique Michael had only read about in historical medical texts: manual bag ventilation, reading oxygen levels from lip color and chest movement, maintaining pressure by hand with a rhythm she could sustain for hours if needed. She taught Michael's residents the technique in real time while saving the woman's life. They took turns manually ventilating while Alina moved to the next patient. Case after case, Alina demonstrated what Michael had dismissed as primitive. It was actually sophisticated medicine adapted for extreme resource limitation. Her improvised suction device worked as effectively as his electric one because she'd designed it based on principles of fluid dynamics. Her sterilization protocols, though unconventional, achieved proper sterilization through understanding of heat, pressure, and time rather than relying on machines. Her monitoring methods, done by hand and observation, caught complications just as quickly because she'd trained her senses to detect what machines usually measured. By dawn, Alina had performed 8 successful surgeries in conditions Michael would have considered impossible. His patient, the one he'd felt helpless to treat without equipment, was stable because Alina had guided him through the procedure, teaching him her improvised techniques while simultaneously operating on another patient herself. Michael stood in the recovery area, exhausted, humbled, and fundamentally changed. His hands were cramped from manual ventilation. His back ached from operating by flashlight. But 8 people were alive who would have died if he'd insisted on waiting for power, for proper equipment, for the conditions he'd thought were non-negotiable. "Dr. Reyes," he said quietly, "I called your methods primitive. I was wrong. I was arrogantly, dangerously wrong." Alina looked up from checking a patient's pulse manually, her fingers on the wrist, counting, assessing with senses Michael had never fully developed because he'd always had machines. "Dr. Harper, your methods are beautiful. Your equipment is extraordinary. Your training is excellent. But medicine isn't about having the best tools. It's about saving lives with whatever you have. We're not better than you were, just trained differently because we have no choice." Michael shook his head. "No, you are better. Better at the fundamental skills. I've been practicing medicine with a safety net for so long that I forgot how to practice without one. You never had that luxury. You had to become genuinely skilled because you couldn't rely on technology to compensate." Over the following weeks, Michael became Alina's student. She taught him to assess patients using observation and touch rather than depending on monitors. She showed him improvised techniques for controlling bleeding, maintaining airways, managing complications using minimal resources. She taught him that the most advanced medicine wasn't about having the best equipment. It was about understanding principles so deeply that you could adapt them to any situation. When Michael returned to Johns Hopkins, he did something unprecedented. He proposed a new training rotation, sending surgical residents to resource-limited hospitals in the Philippines to learn from doctors like Alina. "We're training surgeons who can only operate in perfect conditions with perfect equipment," he told the department heads. But perfect conditions don't exist in disasters, in poor communities, in the places where doctors are needed most. These Filipino surgeons aren't practicing primitive medicine, they're practicing adaptive medicine at the highest level. The program was approved. Now, every Johns Hopkins trauma surgery resident spends 3 months training in the Philippines, learning techniques that don't appear in American textbooks but save lives when everything else fails. Alina became a visiting lecturer at Johns Hopkins, teaching American surgeons the improvisation skills they'd never needed to develop. And Michael wrote a paper titled "Primitive or Profound: What American Surgeons Can Learn from Resource-Limited Medicine," that challenged the medical establishment's assumptions about what constituted advanced care. Years later, when COVID-19 overwhelmed hospitals worldwide and supply chains collapsed, the techniques Alina taught, improvised ventilation, resource conservation, adaptive protocols, suddenly weren't primitive anymore. They were essential. Doctors globally scrambled to learn what Filipino medical professionals had been doing for decades out of necessity. The surgeon who'd dismissed Filipino techniques as primitive now teaches them as advanced skills, critical for any doctor who might face crisis conditions. And he keeps a photo on his desk. Alina, operating by flashlight during that typhoon, saving lives with primitive techniques that proved more sophisticated than any technology he'd brought. Because true medical excellence isn't measured by equipment, but by the skill, knowledge, and resourcefulness of the hands that heal.